This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I interview Carolyn Vandyken to discuss connecting the pelvic floor and psychosocial factors with lumbopelvic pain. During our discussion, we talked about the necessity of treating all persistent pain from the assessment onwards from a broader perspective, including assessing for pain hypersensitivity, psychosocial considerations, and mechanical factors from the beginning. Carolyn is a physical therapist with over 39 years of experience, educator, researcher, and advocate in the areas of low back pain, pelvic health, and pain science. She became an MDT credentialed therapist in 1999 and holds a cognitive behavior therapy certificate from Wilfred University and has been practicing in the field of pelvic health for the past 25 years. If you find this conversation interesting, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share with other clinicians who could benefit from our conversation. Thank you for tuning in, and we hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything Anytime EMR. Systems for PT develops systems for clinicians so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Sarah Health. Have you heard of remote therapeutic monitoring? Does it sound complicated and hard to implement at your practice? It doesn't have to be. Sarah Health is revolutionizing RTM, making it straightforward for your practice. From easy onboarding to hassle-free billing, they cover it all. Hi, Carolyn. Welcome to PT Pro Talk. How are you today?
I'm well, Mariana. How are you?
Good. I'm really good. Spending some time in Brazil with my family, so it's exciting. Yeah.
Excellent.
So let's just get started talking a little bit about yourself and your background, your career.
Okay. Well, my name is Carolyn Vandyken. First of all, thank you for inviting me to come and speak to you today. I always love speaking to other physiotherapists about what we do. And so I graduated as a physiotherapist with a bachelor's degree. We were just talking about that almost 40 years ago, so 39 years ago. And I've been practicing mostly in orthopaedics and in pelvic health, and I would say in pain science. So I'm kind of one of those clinicians that has melded a couple of different, what I like to talk about is silos. So many of us kind of work in one area or another. And I try very hard with my patients to bring those three areas together. So orthopedics, pelvic health, and pain science. And I have been primarily a clinician my whole career. I did get into research probably about a decade or so ago. And I got into research really just asking some good clinical questions. That was really the thing that drove that piece. I specialized in pelvic health almost 25 years ago. And so I then started teaching pelvic health courses. So in Ontario, Canada, which is where I'm from, there were very few pelvic health clinicians as early as even 10 or 15 years ago. So 2010 in Ontario, which is the biggest province in Canada, we only had a handful of clinicians who practiced pelvic health. And so myself and Nellie Fagani started Pelvic Health Solutions in 2010, and I did a lot of training and teaching. I also still continued to practice clinically. And then in 2019, I sold that practice to Nellie, and she continues to run Pelvic Health Solutions. And then I started a second teaching company with really my main passion right now is to break down some of the silos that we work in. And I really want clinicians and physiotherapists to build their skills and cross-pollinate their skills between orthopedics, pelvic health, and pain science. And so that's predominantly what I do. I do some teaching, I see patients, and I continue to do some research. Been lucky enough to develop a Fremantle Perineal Awareness Questionnaire, which is a sensory motor questionnaire for perineal pain, along with Dr. Ben Wand in Australia and Dr. Judith Thompson and Jilly Bond. So I've worked with some really cool and interesting international people to look at the research piece, and that's been a lot of fun as well.
That's awesome. I love that you're integrating all those pieces, the psychosocial, pelvic, and orthopedic. So I think it's going to be very interesting to just talk about all of them and how we integrate them.
Yes.
So let's start talking a little bit about the problem of MSK. So we know that, our statistics for disability associated with MSK is very problematic. So why do you think that is?
So, I think certainly when we look at big systematic reviews, our MSK disability, and we can just even talk about low back pain if we want to simplify it. But, if you're a clinician and you treat other things besides low back pain, the disability numbers continue to increase regarding MSK pain over the last couple of decades. So we just all need to take a step back and say, collectively, not pointing any fingers at anyone, including myself, collectively, we are not doing a great job. If people continue to increase the bar with the number of people that are disabled from MSK conditions, we have a problem. That is especially true in low back pain. So year over year, the disability associated with low back pain continues to rise. Right? We have MRIs, we have imaging, we have specialists, we have surgery, we have so many options to treat low back pain, and yet more and more people are disabled. So there's a couple of reasons for that. One is we are all trained as biomechanists, right? And so we think about the biomechanical components of kind of MSK pain. And where the research has taken us over the last 10 to 15 years is to take a step back and really understand the person in pain, really, and start to understand that tissue components of pain rarely help us understand a persistent pain problem. So we spend all our time and energy and money taking courses to teach us how to assess joints and do manual therapy and do all these great things. But at the end of the day, chronic MSK conditions are not well correlated with actually what's happening in the tissues. So that's one problem. We are trying to fix tissues and we're trying to focus on the tissues. Another problem is that we tend to focus on just a silo of kind of what our specialty is. So if we're an orthopedic clinician, we're going to look at the joints and the muscles of the back, the spine and the hips. If we're a pelvic health clinician, we may focus on the pelvic floor. We may or may not look at the spine and the hips. And if we take more of a holistic sort of biopsychosocial approach, we may just think more about the central nervous system and everything that's happening with the central nervous system. But really, when we think about biopsychosocial, it needs to involve good tissue involvement in the pelvis, in the hips, in the low back for low back pain, and then understanding the person in pain. So we have to do all of those things. And I would suggest that many clinicians aren't upskilled in all of those areas. And so it's a struggle.
Yes, absolutely. Because we just tend to be very specific in our little area, as you said, and forget to look to everything else. So you get really good in your skills in one thing, but you're not being able to identify when you should be doing one thing versus the other and so far. So what is the solution, in your opinion? So how do we start?
I think, first of all, we need to start by really understanding persistent pain, right? In persistent pain, so what is persistent pain? Pain that lasts longer than 3 months, right? In persistent pain, the tissues are healed, right? Now, I didn't say earlier, I'm also Mackenzie credentialed. And so I feel very blessed to have learned early in my career a systematic way of looking at spinal pain, for example, that doesn't focus on pathology. It focuses on patterns of pain and directional preference and teaching people how to move again in a way to settle down sort of mechanical sensitivity, right? So the very first thing we have to do is start to think about pain from a more broad perspective. If they've had pain for longer than 3 months, this is a quote from Sandy Hilton, who I've taught with for a long time and done some writing with. If they have persistent pain, the tissues are tight, the tissues are weak, or the nervous system is too protective. It kind of boils down to those three things, right? So the very first thing we have to do is take a step back and say, is this actually, and again, we'll go to the pain classification systems as identified by the International Association for the Study of Pain. Is this nociceptive pain? Is it nociplastic pain? Is it neuropathic pain, right? And look at every patient from the beginning through that lens. I think what many of us end up doing is we start with the tissues, and then if that's not working out so well, if we're not able to resolve the problem, then we start thinking about some of the psychosocial factors and the yellow flags. But then when you make that turn kind of halfway through treatment, sometimes patients, I don't know if you've ever had this experience, Mariana, but sometimes patients will say to you, now you're telling me it's in my head. Mm-hmm. At first you were treating my disc problem, for example, but now you're telling me it's in my head, right?
Yeah.
And if we're really clear, so, if they have a directional preference, if we do a good mechanical screen, that's nociceptive pain, right? There's tissue sensitivity. And we have some good evidence, even as far back as Audrey Long's study, which I thought was a brilliant study back in 2004 that was published in Spine, that if someone has a directional preference and we treat the directional preference, they will resolve quickly, right? If they have back dominant pain, their pain should resolve in the directional preference in 2 weeks. Right. But if we start right from the beginning at looking for all the factors that may be contributing to their pain story, maybe some of their pain, maybe 60% of their pain improves with a mechanical approach, but the rest of it needs to be addressed maybe through what we call nociplastic pain mechanisms, which just means the central nervous system has also, with their persistent pain, gotten into a more protective state. Right. And if we explain to patients from the beginning, listen, there looks like there's a mechanical component here. Let's address that. But there's also, it looks like your nervous system is in a more sensitized state, and we can use questionnaires and take a good history to develop that clinical rationale. And it looks like you're presenting with some moderate sort of low mood or depression, and maybe you've got some sensory motor dysregulation. And so we're going to address those pieces as well. Now we've built the story from the beginning, and we can go through that whole process with the patient. And when we start talking about the psychosocial pieces or the central pain mechanisms, our patients aren't going to look at us like we're changing the story on them, right? Yeah. We've sort of given them the whole perspective from the beginning. And when we start like that, we are going to be much more successful, much more quickly with our patients.
Yes, and it makes total sense, because if you just start out doing all the mechanical assessment and then improve some, but not much, or sometimes don't improve at all, then you change, it gives that impression that you don't know what you're doing. I tried something and it didn't work. Now I'm going to switch gears and try something completely different from what we were doing.
Yeah.
So I think that having that since the beginning is the key. And I think a big problem, at least my experience, we don't screen for that in the beginning. The questionnaires on those clinics, the big main clinics that I worked, nobody ever screened for all those factors. So you don't have any basis to not even start the conversation, or as you said, set the stage for what's going to come, because you don't know which direction you're going to go. But then if you have that conversation up front, you are prepared to go in any direction that you see that's necessary to go. So I think that makes all the difference. And most PTs are not preparing that basis to be able to have the conversation when the conversation needs to happen.
Yeah. Yeah. And Mariana, that's a really interesting observation, having worked in different practices. What do you think the barriers are? Because now I'm going to flip the tables here a little bit, because I think this is a big problem, right? And I can tell you what I do, but what do you see the barriers for physiotherapists to integrate a more thorough psychosocial screening right from the beginning?
I think that one is most PTs don't have the knowledge. I think they don't know the importance, or they never heard about, or they don't even know how to address. Even they screen for it. I think that we are not overall prepared and trained on that psychosocial, because we all talk about, we are here about, but what it means in practical terms. How do you screen? And then you screen, then what do you do? I don't think we have the training.
Right.
And then the second thing, I think, is just paperwork. That people are afraid of
Right.
giving too much paperwork. Patients are already, 10, 15 minutes filling out paperwork, and then you're going to just add more. So if you want to add, you have to know what you're going to do with all of the paperwork, not just screen for screen. You have to have a purpose and know what you're going to do. And I don't think we are prepared.
I think that is a brilliant sort of assessment of kind of where we are at as a profession, even though the research has been calling for more than a decade, maybe 15 years, for us to take a broader perspective. And we know the importance. Like if you say to a clinician, yellow flags, everyone knows what that means, right? But it's almost like we historically have screened yellow flags to kind of pin the blame on the patient when they don't get better. Oh, you've got these yellow flags, so you're not likely to benefit from my treatment, right?
Mm-hmm. Mm-hmm.
Versus saying, you've got some comorbid self-reported anxiety and catastrophic thinking, for example, if we want to pull two out, right? And, when those are part of your presentation, we really need to help you understand about the pain system. That's probably the most important strategy for catastrophic thinking. And maybe we need to think about using a worry journal to contain your worry or your anxious thoughts so you're not in that state all day long, right? So some very simple things that can make a profound change to their nervous system from the beginning or within the first couple of sessions. And now you're building on kind of their opportunities to change their system and to become more resilient.
Yeah, I just feel like that's not our scope. Like we feel like that's nothing related to do. Like there is nothing to do with me,
Yeah.
It's not my place to do that. When we know that we are seeing all this literature and all these changes happening, and we know that those patients that they don't get better, we all recognize that something is wrong, but I feel like we just don't know what to do.
Right. So I went to the International Association for the Study of Pain, their conference in 2018. And the keynote speaker at that conference, who actually won the big IASP award that year, he was actually, if I'll remember his name or not, he was from Europe, actually. Anyways, doesn't matter. He said in his keynote address, listen, the time has come. We're all clinicians who treat mechanically or treat the tissues, whether you're a physician or whether you're a physiotherapist. We need to address the psychosocial and the mental health pieces. We need to stay within our scope, but there's lots of things we can do within our scope to address those pieces. And if you're a mental health provider, you need to address the body. We can no longer. So if you treat pain, by definition, pain is a sensory and emotional experience that protects us from actual harm, like when we injure our tissues, or potential harm when I'm, going too close to my tissue tolerance. It always feels like you've damaged the body. So that's the definition of pain. And if pain is sensory and emotional, I'm going to take a step here and say, we have no business treating pain if we don't treat both the sensory and emotional components. It's always sensory, it's always emotional. It's not or. So you should not be treating pain if you're not prepared to address the sensory and emotional components.
Yeah. Yes. And so how do you screen for that, like in your practice? So how do you go about using questionnaires? So how is that process?
Mm-hmm. Yeah, great question. So there's a couple of different ways we can do that. First of all, I would like us to rethink how we refer to these questionnaires. Let's stop calling them outcome measures, because outcome measures are just a pain in the rear, right? Outcome measures are just more paperwork. Someone's looking at them out there, measuring our success, like that's how we think about outcome measures, right? I would like us to think about these as assessment tools. They're just as important as doing range of motion measures, strength testing, special tests, all the things we're really comfortable around kind of assessing the tissues. These are basic measures that need to be used with every person in pain to assess the psychosocial and emotional contributors to their pain experience. And so there's lots of kind of screen the screener questionnaires. So for example, the start back questionnaire, the yellow flag screening questionnaire can be used for kind of general orthopedic kind of conditions. In pelvic health, there's a brand new questionnaire that's been validated. That's kind of a screen the screener. And I just call it screen the screener because it just means it gives us a brief overview of all these constructs. And then we can dive deeper into the constructs that they are actually presenting with. So in pelvic health, we have a new questionnaire called the 3PSQ, or the Persistent Pelvic Pain Questionnaire. And it measures depression, anxiety, stress, catastrophization, health anxiety, fear, sexual assertiveness. So there's about 10 or 12 questions, one question dedicated to each construct. And the constructs that I teach about in my course and that I measure with every single one of my patients, I've come up with this mnemonic called SAD cliffs, right? Mm-hmm. And SAD cliffs just stands for, SAD is stress, anxiety, depression. We need to be measuring that in all of our patients. CLIF stands for catastrophization, low self-efficacy, low positive affect, or glass half full, glass half empty, injustice, fear, shame, and sensory motor dysregulation. So what I do with my patients is everyone gets a screening questionnaire. They fill it out ahead of time. It has all the basic kind of health information that we typically get, which allows me then, when they fill that out, to actually sit down, put down my pen, and really listen to my patient, because I know the data is collected on the form. And then I can just make a few highlight notes, but I can really engage, because when we're really actively listening, we develop therapeutic alliance. It's probably the strongest predictor of success with a patient, right? So I'll do a general kind of intake information, and then I give them the 3PSQ, because most of what I see is pelvic health. I give them an insomnia severity index, because that's not picked up on the 3PSQ. I give them the central sensitivity inventory, part A and part B, which measures overall the sensitivity of their nervous system and is connected to psychosocial distress. And I give them a sensory motor dysregulation questionnaire called the Fremantle Awareness Questionnaire. And I give them one for their back and hip if they have back or hip pain, and they also do a perineal awareness questionnaire. So it probably takes them about 20 minutes to do all of that paperwork. And I send it out very much with a proviso that says, at our clinic, we take a whole person approach. The more information we have sort of coming into the assessment, the better we can really understand your whole problem. And just fill out anything that's appropriate. If something doesn't feel appropriate or you don't want to fill it out, feel free to leave it blank. So again, it's not going to, and I say it's not going to affect the quality of your care, like just giving them an option, right? I would say I get 95% completion rate. And the majority of patients will say afterwards, thank you for really doing a thorough assessment. I really feel like you understand my problem.
Wow. I would not expect that. I would expect people complaining about having to fill out paperwork.
I would say less than 1% of my client caseload will say, oh, that was so much paperwork. That was terrible. Right? Patients just want to be heard. They want their story to be understood. They want you to understand. And when you start with some screening questionnaires that look at distress, I call it mental health distress, right? They feel validated when they start to tell you that, they notice that when they're anxious, their pain is worse, right? Or that when they're stressed, their pain is worse. They get that. And it gives them an opportunity to talk about it.
Yeah, just having someone acknowledging that happens and validating them, because they just think that it's weird, right? Like, why I'm stressed, and then like it's my fault because I'm stressed, and like all of that. So just having a professional acknowledging that, I think it's very important.
Yeah. And really listening to their story. I think so often we try and get so quickly through the history so we can do the physical exam. And I would say 50% of the time with my patients, all we do in that first hour is the subjective eval. And I really listen to their story, and I really talk to them and understand kind of all the different components. And often clinicians are afraid to do that because they're like, my patient expects a physical exam. Right? And so I'll say at the 45-minute mark, I'll stop and I'll say, okay, we've got about 15 minutes left. We're not quite done the history. How important is it to you that we finish the history and just get the whole story? Or is it more important that we stop and start to do a physical exam and look at your tissues? Which would you rather do? 90% will say, this is really great. This is really important. And I want you to understand my whole story. We'll do the physical exam next time. But just ask your patient.
Yes.
What do they prefer? Right?
Yeah. Give them the control as well.
Yeah. Right. Yeah. Very important.
And then, so how do you go about doing the mechanical screen and then the psychosocial if they have both components? So how do you go about that? Do you always do one first and then the other, or do you go do both at the same time? So how do you structure your treatment?
Right. So again, I mostly see pelvic health. And so I do the full sort of subjective eval, which includes a psychosocial baseline screening. And then I will start with a physical exam of the lumbar spine. With every pelvic health patient, I will do a range of motion test with them of their lumbar spine and their hips. And then I will do repeated end range movement testing with them, looking for a directional preference. But I can scan the spine. Now, I'm not talking about someone with radicular symptoms. This is for people who have back dominant or hip dominant kind of pelvic symptoms or their dominant piece. I can do a good mechanical screen in 10 or 15 minutes. We can ascertain the presence of directional preference or not in 10 or 15 minutes. So sometimes in that first eval, I will do the subjective eval for 45 minutes. And then if we're done, again, in one of the things that you're really working on, your first goal is therapeutic alliance, right? Having the patient feel worthy, listened to, respected, right? You've heard their story. Repeat. So a good motivational interviewing technique is at the end of the history, put your pen down and say, okay, let me see if I got this right. And do reflective listening. Reflect back what they told you and then say, and did I get that right? Is there anything else that you want to tell me? Did we miss anything? It's that I really heard you, and here are your concerns. Here are your problems. This is the story you've told me. Take a minute or two and summarize what they've told you. And then I'll start a physical exam. And usually I can usually get that screen. If I'm going to do something in that first visit, it'll be to screen their hips and their lumbar spine mechanically. And then if I'm going to do a pelvic exam, that will happen on the second visit, for example, if they're ready for it, of course.
Okay. And I'm just curious to ask you, so people that come to you with complaints of pelvic pain or dysfunction or issues, and do you see a lot of hip and back that you screen mechanically and then they affect the pelvic area, pelvic pain?
I would say, 40% of my pelvic pain patients have a spinal component to it.
That's a lot.
Yeah. And so I think often if we're a pelvic health clinician and we're not screening the spine, we're missing that piece, right? And so addressing that piece first, it's something that patients are more comfortable with. They're expecting that. And then I can explain to them about why we may want to do an internal exam, what their options are, what that will tell us, and kind of where we go from there as well. But I think screening the spine is key. And that's where I'm very grateful for my Mackenzie training and my ability to quite quickly ascertain, is there a directional preference here or not?
And you would miss a lot of patients if you are not screening for that. And then how do you see the difference? Is the pain that they describe that gets better? How do you create baselines with the pelvic patients?
Yeah. So if they've got a baseline pain, if they've got pain, that's easy enough to kind of track and follow pain, right? It's a little harder to track and follow something like urgency, for example, right? Although I have had patients who say, you stand them up, I've got no symptoms right now, for example, and then you bend them forward and I'm fine. I bend them back. Oh, there's my urgency.
Wow.
Right. Okay, so let's do a whole bunch. Yeah, I'm actually feeling more urgent now. Well, let's do some flexion. Oh, I'm feeling less urgent now, right? Or I'll get men with penile pain, for example. There's my penile pain. Oh, okay, now my penile pain is better. And so we can see a directional preference in referred pelvic symptoms. Or there's my pressureness. So one of the symptoms we often treat in pelvic health is pressure, right? This feeling of pressure, heaviness. And so often when we have pressure, heaviness, the patient thinks, and we often think that has to do with prolapse, right? But I don't know if you've noticed this as well in your pelvic health clients, but when there's tenderness and tension in the pelvic floor muscles, that can also present as heaviness, right? And so we can have other reasons to feel kind of that heaviness or that pressure other than just a prolapse sensation.
Mm-hmm.
So that's easy to monitor. That heaviness is, I guess, what I was saying there, right?
Yeah. I was just curious to ask what other symptoms that you track with those patients.
Mm-hmm. So I will track whatever their baseline symptom is, right? So if they stand up and they have some urgency, so if we're going to start our physical screen, do you have any sensation of having to go to the bathroom right now?
Mm-hmm.
Yeah. How intense is that sensation? If 10 is I need to go right now and 0 is I don't feel like I have to pee or I've got some bowel pressure, and then I'll track that symptom as well.
Mm-hmm.
So I'll track their urinary symptoms, but I'll also track their pain wherever they're having pain or numbness or tingling.
And do you have clues in the history that those symptoms are associated with movements or positions? Or sometimes there is no relation at all?
Yeah, so sometimes and sometimes not, right? So and sometimes patients haven't made that correlation themselves, right? So you will often see people say, I often feel urgent when I go from sit to stand, right? It's that I'm fine when I'm sitting, but all of a sudden I go to stand and I have to pee right now, right? That's always curious to me, right? And sit to stand often is someone who is a flexion responder and doesn't love going into extension, for example. So we can see that kind of clue, but you really just have to then do a good physical exam and see what you're finding on physical exam, right? And for me, the physical exam dominates the subjective exam, right? If I'm seeing something on physical exam, I'm going to follow that first and see where that brings me.
Yeah. And do you see a most common direction that they respond?
It's interesting. In my pelvic health patients with comorbid low back pain, I would say that I see more flexion responders than extension responders.
Very interesting.
Yeah. Especially patients now I tend to see an older female population. So I work in practice with my daughter. She tends to see a bit more of the pregnancy, the younger gals I tend to see. So definitely in my older gals, I see more flexion responders than extension responders. Maybe to a 60-40 split if I had to guess.
Wow.
If they're going to be mechanical, and even my males with penile pain, I can remember this fellow that I saw whose main complaint was low back pain and penile pain. And he developed his penile pain after a long sexual episode where he had prolonged intercourse. And he then had ejaculatory pain and pain at the tip of his penis, and he had low back pain. But his history in low back pain, he was an extension responder at one point. About 10 years ago, he had an episode where he was an extension responder. And when I look at this patient population, what they often end up doing, and where we can sometimes go awry in the McKenzie system, is we sometimes leave them with this feeling of you need to protect extension. You need to kind of, keep guarding in that direction and minimize too much flexion. Flexion has got you into trouble. And in that episode, that was true, but I don't think we should leave people with those long-lasting instructions, right? We should leave them with a lot of variability in their movement. And so this particular fellow got into the habit of just guarding his flexion. He kept himself quite erect in his spine. And so you can imagine he became quite mechanically sensitive to extension because he lived his life in a more extended position. And that's when his penile symptoms would come on. So when we flexed him, his back pain got better and his penile symptoms got better. Right? So, I whether it's a 50-50 split in my patient population or maybe a little bit more towards flexion, I would definitely say it's not more extension based.
And I was going to ask you, why do you think that it's different from the most back patients that we see that respond more to extension than flexion? Any theories?
I wonder if there's a pelvic health component to it, right? And I see an older population where I would say the average person with mechanical low back pain is more in their 30 to 50 kind of age frame. And when I'm seeing more postmenopausal women or, sort of maybe some men who tend to be in their 50s or 60s, I think often we may see more flexion responders at that time in their life. And I believe I've been McKenzie credentialed for 25 years. I believe that we have a bias in the McKenzie system to extension, and that we're looking for extension responders too much sometimes, right? Yeah. And we try and make them fit a pattern. And I think as well, when we don't take a good biopsychosocial approach from the beginning, and we're missing the psychosocial pieces, our tool in our toolbox is to make them mechanical. And I've been there, I've done that, right? But when you really have a much broader toolkit from the beginning, it's okay if they're not mechanical. It's okay. That's why I can do a good mechanical screen in 10 or 15 minutes. I'm not going to fiddle and make them mechanical, which I did for a long time, right? They're either mechanical or they're not. And if they're not mechanical, that's fine. We've got lots of other things that we can do to change the pain system.
Yeah. And do you have a lot of men looking for?
So about 30% of my caseload is men.
Oh, wow. Okay.
Yeah. Very few of them post-prostatectomy. Most of them chronic low back and hip pain with some, sort of burning, urgency, frequency, overactive bladder kind of stuff happening. Some stress incontinence, but I would say in some ejaculatory pain, that kind of stuff as well.
Interesting. And how about the hip? I was just curious to ask you, do you see a lot of relation of hip with the pelvic pain? Yeah.
Significant hip correlation to pelvic pain. And so, particularly what I like to call the C sign. So patients who have dominant symptoms in sort of trochanteric, groin, kind of deep buttock. I think the piece that's missed in that patient population is the deep stabilizing rotators of the hip, which are only found inside the pelvis, so the obturator internus and the piriformis muscles, which again are highly connected to your pelvic floor because they suspend your pelvic floor muscles. What we have to remember about the pelvic floor is that those muscles are highly responsive to stress. Right? Kind of like our neck muscles and our trap sort of tension and headaches and TMJ pain. All of those kind of conditions are highly connected to stress. And we have some good research from Vanderveld's work in 2001 that looked at when you show women very frightening film and put muscle sensors over her body, the first two muscles to respond is her neck and shoulders and her pelvic floor. So that is a protective response in the body, right? So when we have someone with hip or back pain and we're not screening for pelvic health conditions, so do they have comorbid constipation, urgency, frequency, in men, ejaculatory pain or pain with erection or difficulties getting a full erection? If we're not seeing if we're screening for and asking for that correlation, we also should be thinking in those hip pain patients that there may be a tension problem or a guarding problem in the pelvic floor.
So do you feel that the hip and the back, they are being the cause of the problem in the pelvis? Or do you feel that also the other way around is true as well? And how often that happens?
I think all we know, Mariana, right now is they're comorbid. So any of the studies, so we did a study in 2015, I think it was published in 2018. We started in 2015. It was published in 2018 that looked at women with low back pain, right? So women with low back pain came to an orthopedic practice for low back pain. What we did was we screened how many of them reported at least one pelvic health condition, and 95% of them did. And then we looked at that patient population and did a double-blind study. One blinded therapist looked at their pelvic floor, and one blinded therapist did a mechanical screen and a pelvic girdle screen. And of those 95% of women who had at least one pelvic health complaint, that was shown on a blinded screen to be identified as either weakness, tension or coordination problems. So all of them had some pelvic floor complaint, okay? But the most common one was tenderness on palpation of the pelvic floor. So historically, orthopedic clinicians have thought so much about back pain as being a core stability issue, right? And that story has been around for decades at this point. But when we look at the kinematic research for low back pain, we've got 2 systematic reviews that show that stiffness and guarding are more problematic in low back pain than in patients who don't have low back pain. So people with low back pain move stiffer and are more guarded. Well, that fits with the tension that we saw and the tenderness that we saw in this patient population, right? And so what does the role of core strengthening play in low back pain as a go-to strategy? I'm not saying that there aren't a subset of patients who need to have a stronger core, but they're pretty small. It's not the majority of patients with low back pain. And that's why I said we really have to break down our silos, right? If we're treating low back pain and we don't understand that in women with low back pain, 95% of them have a pelvic floor complaint, and 71% of those women have overactivity in their pelvic floor. Once we settle down that overactivity and teach them to relax the system, many people will have their low back pain go away. We haven't done any strengthening yet. All we've done is settle the system, right? Mm-hmm. But if they have a mechanical low back piece, I always address that first because it's quick to fix, or that's the wrong word. It's quick to change, right? See how we use such fixer language, don't we? Mm-hmm. But they can change that sensitivity, that mechanical sensitivity really quickly.
Yeah. And how do you assess to see, as you mentioned, if it's tight, if it's weak, or if it's the central nervous system?
Right. Okay. So the pelvic floor piece, like how do you assess that? Yeah. So you need to so first of all, the research over the last year or two is really pulling us away from this idea of tension, right? It's more tenderness. And the research right now says we can't objectively measure tension in the pelvic floor in the clinic. We just don't have the tools currently to do it. And what we feel under our fingers is unreliable, right? Tenderness on palpation is a more reliable construct at this point. And I'm really excited about that because that actually fits with what we see with central pain mechanisms. So Keith Smart did a Delphi study in 2010 looking at how do you predict people who have central pain mechanisms dominating their picture. And so the first characteristic is hypersensitivity to touch or disproportionate tenderness on palpation. So allodynia or deep pressure hyperalgesia, right? What we would used to call trigger points. And again, we should be dropping that language. If we haven't, please drop that language. Read Denany's paper in 2019. There is no definition of trigger points. We should stop talking about trigger points. And I think it's important from a patient perspective because it pathologizes the muscle. And we have to move away from pathology and persistent pain. The tissues are tight, the tissues are weak, or the nervous system is more protective than it needs to be, right? So if we go back for a sec and we think about tenderness, so the first thing we should be checking for is allodynia. When I do an internal exam, the first thing I'm looking for is, does light touch cause pain? In Keith Smart's Delphi study, what he showed was allodynia or pressure hypersensitivity has a 30-to-1 odds ratio that central pain mechanisms are dominating their pain picture. Mm-hmm. A 1-to-1 odds ratio is statistically significant. So a 30-to-1 is highly predictive, right? So almost every one of your pelvic patients who has tenderness on palpation, that's a top-down mechanism. The brain has learned to protect or guard that area. Okay. The second characteristic is, do they have they had pain for longer than 12 to 16 weeks? If the answer is yes, there's a 26-to-1 odds ratio that central pain mechanisms are dominating. The third characteristic is their pain spreading? So if their pain started in the right hip and now it's in their left hip, for example, that's what we call diffuse pain or mirror pains. There's a 16-to-1 odds ratio. I think it's 15-to-1. And then if they have fear and catastrophization, which again, we need to measure, there's a 7-to-1 odds ratio. So we can take a good history, do a good physical exam, and start to look at what is the likelihood of this being a centrally mediated problem versus a peripheral problem,
Mm-hmm.
right? And so you're looking for tenderness and palpation, and you're looking for, let's say they have left hip pain, left deep glute pain, and the only tenderness I'm feeling is in the left obturator internus and the left piriformis. I'm happy to treat that as a muscle problem, right? If everything else is sort of playing out that way. They just, sometimes we see skaters or dancers or people who spend a lot of time balancing on one foot develop a lot of tension in the system that is designed to hold the ball in the socket, right? We don't pay enough attention to those deep muscles and how they add to the pain, the hip pain story, right? And again, I have a very biased pain population. I get to see all those hip pain patients that have failed with everyone else, right? And what do I see? I see either a low back issue that's been missed and is referring to the hip, or I see a pelvic floor problem that has been missed and is causing hip pain, or I see a central pain mechanism, a nociplastic pain problem that has caused the nervous system to overguard or overprotect the hip.
Mm-hmm. And do you see a lot of hip derangements?
That's a great question. I don't. And maybe because I have this pelvic health skill, right? That I look internally for some of those, that disruption. Occasionally I will see an extension responder in the hip, for example.
Mm-hmm.
I will definitely see that occasionally, sometimes a hip flexion responder, but mostly I will see a mechanical spinal piece or a pelvic health piece that will resolve kind of that hip pain. But maybe I go there quicker than someone who doesn't have internal palpatory skills.
Mm-hmm.
I'm going to acknowledge that may be part of that. I don't have to look so hard for that directional preference in the hip.
Yeah. And on the psychosocial aspect, I thought it was very interesting that said, Cliffs, that you share with me and the approach that you take to address each factor. Would you like to just briefly talk about, so you screen, you found something, so then what do you do?
Yeah, so that's great. So we have some real good evidence from different sort of bodies of literature. So some from the psychology literature, some from the physio literature. What we really need to be clear about as physiotherapists is that we're treating pain. As soon as we're treating psychology or we're treating relationships, for example, we're outside our scope. But if I'm treating pain, if pain is my target, then I can stay within my scope. So, for example, if we think about stress, we have some really good research that evoking the relaxation response, which is a term that Dr. Herbert Benson created from Harvard, evoking the relaxation response. In other words, doing something meditatively to quiet the central nervous system. And it could be meditation, it could be yoga, it could be Tai Chi, it could be Qigong, it could be breathing exercises, right? If someone's struggling with stress, we're probably going to do something to target evoking the relaxation response. If someone's struggling with anxiety, we may do some grounding techniques. We may bring them back into their body. Where is anxiety felt? Anxiety is felt in the body. We can help patients to sense their bodies better, to do a body scan, to start to, if they're feeling anxious, practice 5, 4, 3, 2, 1. Tell me 5 things you can see right now, 5 things you can hear right now, 5 things that you can touch right now. Now tell me 4 things that you can hear, 4 things that you can touch, and you just go down the scale that way. It's a great technique for bringing them back into this moment and bringing them back into their body, right? If there's some psychology behind why they're feeling super anxious, that's for the psychologist to unpack, right? But I can certainly teach them how to calm down that anxiety and to be more present. Mm-hmm. And sometimes that's enough to just break the loop. Mm-hmm. Right? The other thing the screening questionnaires give us is kind of a scale of their self-reported behavior. So if they're on the depression, anxiety, stress scale, if they're scoring in the severe category of self-reported anxiety, which is how I would say it to a patient, I would never say, you are anxious. I'm not a diagnostician, right? It's not my job, but you're reporting severe anxiety. have you worked with a counselor before? If they're in the moderate category, I'm happy to teach them grounding and maybe a worry journal and some evidence-based approaches to managing that. But if they're severe or extremely severe, that requires a team. But now I have some evidence with them to build the need for that team, right? So that's stress, anxiety, depression. Exercise is so important in depression. Whether it's resistance training, whether it's cardiovascular exercise, yoga, for example, all of those have evidence in depression. When we think about catastrophization, the most evidence-based tool we have for catastrophization is pain education. Those are the patients we should be doing pain education with, right? When it comes to low self-efficacy, right? Not feeling confident that I'm in control, those are patients who should not have manual therapy. Right? We should not be doing passive treatment with people who have low self-efficacy, low positive affect. We can do meditation. We can exercise. We can build their control over their system, right? Injustice is about anger and feeling like someone did this to me. It's not fair. It's someone else's fault, right? We see that in our MVA patient population. We see it in our workers' comp population, right? And those are probably people who need a bit of counseling around that piece. Right? That would be a good psychological referral, probably for forgiveness and working through some of that piece, right?
Mm-hmm.
Then we have fear, pain education, so important in fear, graded exposure, right? Using a fear ladder, some cognitive functional therapy techniques to expose them to their least feared activity and then slowly to their most feared activity. Shame, we see a lot of shame in pelvic health. Right. Shame essentially means I am bad. Guilt is I did something bad. That's okay. We can all feel guilty now and again. But shame at the core is I am bad. That is a real problem, right? Again, a good self-compassion is important. So we can turn them towards self-compassion meditation, but probably also to some counseling. Right. And then the biggest last S of Sadcliffe's is sensory motor dysregulation. And I could spend another hour talking to you about sensory motor dysregulation because it is an untapped resource in teaching their nervous system to feel safe again through novel sensory motor exercises. Right. We have the Fremantle questionnaires now, which Ben Wand has created in Australia to measure sensory motor dysregulation. In low back pain, when they did the initial study on sensory motor dysregulation, 95% of people with chronic low back pain had sensory motor dysregulation. It's motor control, but it's much more than motor control exercises. It's all about creating safety in their nervous system with sensation and movement again. And that is really a passion of mine. I think we can do so much in that area to quickly change people's nervous systems and create more safety.
Very interesting.
It's very targeted. I think that's the piece, right? It's not just, they're sensitized, do pain education.
Mm-hmm.
I think that's where we run amok, is we think everyone, with a more sensitive nervous system either needs to meditate or do pain education or maybe do some yoga or breathe. Why don't you just breathe, right?
Mm-hmm. Mm-hmm. I was just curious to ask you more about the sensory motor dysregulation.
Sure.
So what is the mechanism? Is the autonomic mechanism that you lose the representation, or is just because you said that's a lot of people that have that? So what is the mechanism behind that?
Yeah, it's a hardwired change in the sensory motor cortex, right? So think about at a very basic level what we all recognize. If someone has had an amputation, they will develop often, not always, but often phantom limb pain. And the reason they develop phantom limb pain is because the representation of that limb is still in their sensory motor cortex. And certain movements or activities can trigger that kind of sensory response or movement response, but the limb is no longer there. So there's this kind of dysregulation that happens between the body and the commanding sort of central nervous system in the sensory motor cortex, right? And so that's just one example. So we used to call it sensory motor smudging. Maybe you've heard that term before, where the sensory motor cortex is no longer really clear with a good map representation of different activities. Mm-hmm. And another example I'll give to people is, when you learn to ride a bike, You cannot ride a bike for a couple of years and you hop back on a bike again and you might be rusty for a minute or two, but you've got that very complex motor and sensory skill of riding a bicycle mapped in your brain, right? And there you go, away you go, and you do it again. Now you switch one thing on that bicycle. So there's a really interesting YouTube clip if you look at the backward bicycle, if you Google that on YouTube, and it's about an engineer who they switched the handlebars so that when you turn left, the bike actually turned right and vice versa. It took him 5 minutes of practice every day for 8 months to remap and rewire his brain in order to ride that bicycle. Right? So he had to unlearn and relearn a new sensory motor map. Well, when we've had pain or when we've had an injury, that map of that body part in our brain often changes. And that actually in fMRI studies, if you tape two fingers together, in 1 minute, the map becomes one. Sensory motor changes are very quick to happen. And if we don't challenge the body part, if we're really fearful, if we're really anxious about using the body part, we can develop dysregulation in how those maps work. So now they have a protective pain response attached to the maps of that body part, or stiffness, for example. Okay. And so we can measure that construct now using the Fremantle awareness questionnaires. And any score above 0 is considered sensory motor dysregulation, where in the low back pain study, the average score for the average person with low back pain who had chronic low back pain was 11. So quite significant sensory motor dysregulation. And the same has been shown in knees and ankles and in shoulders. Sorry, knees, necks and shoulders and low backs.
Yeah. Well, a lot to absorb. And what do you advise to clinicians that are they want to improve their skills on the psychosocial? That I feel like it's a big area that we all need to improve. What do you recommend them?
I would say the first step that I took was really to take a good pain education course. If you yourself don't understand the neurophysiology of pain and how that works, I think that's the first step. And then the second step is to really take a course that puts some framework around how you look at patients with nociplastic pain, right? So I want to say it's Annie O'Connor. Do I have that name right? Yeah, Annie O'Connor teaches a really good course in the States. I teach some courses on that. The Noy Group in Australia teaches some courses on that. Joe Neisch, a Belgian physical therapist, teaches some great courses on sort of framework approaches. So again, you need a really consistent framework to look at these patients and to have some strategies. As you said, that's one of the barriers, isn't it? Is we don't know how to assess it. And then when we assess it, we don't know what to do with it. So then we just stay in our lane and think, well, I'm just going to do what I know what to do. But we're failing our patients. The statistics will show that we're failing our patients, right? Yeah.
And any resources of information that you recommend our guests to look into?
I mean, certainly if the neurophysiology of pain is not something you've looked at before, you probably need to start with Explain Pain, which is the Bible probably in this area. And then Adrian Lau's work, I would say as well. He's got a website. I think it's called Why Do I Hurt, or Why We Hurt, maybe. But if you Google his name, there's some good resources there. The NOI group also has some really great resources in this area. We have put a lot of our resources on Embodia Academy, and there's some online courses that you can take through that. And certainly following Lorimer Mosley has a new podcast that he's doing. That's worth a listen to. And I think people like Joe Tata are doing a great job in the US as well, looking at really an integrative rehab approach. So there's lots of different resources out there, but it's really committing to looking at your patient as a whole person.
Mm-hmm. Yeah. And anything else that you want to mention that we haven't talked that you think it's important, or you think we covered pretty much everything?
We covered a lot, didn't we?
Yeah,
We covered
you
a
did.
lot. And I know it feels overwhelming, but change requires just one step, right? We need to take a step in the direction of more integrative rehab, right? And we, although it's comfortable to stay where we are, I'm just going to reiterate that the research would support that we are not moving in the right direction. And if you really want to challenge that sort of biomechanical thinking, Google Dr. David Nichols, Nichols. I believe he's from New Zealand. And he wrote a book called The End of Physiotherapy. And he predicts that if we don't get out of the biomechanical model, that the privileges that we now enjoy as physiotherapists will go away, that we will lose our place in the medical system if we don't embrace a broader framework. So he's a bit of a doomsday guy, but he uses sociology to make his point. And we have to become physiotherapists for the average person. This can no longer be a treatment approach for the privileged and the people who can afford our services, right? We need to broaden our base more effectively. And to do that, we have to stop making it so difficult. We make it far too complicated. It's not that complicated.
Educate ourselves to be able to integrate a lot more different knowledges and treat the patient, as you said, in a broader.
Keep it simple. Keep it simple, right? Yeah. Don't make it so difficult.
Yeah. And for the clinicians that are starting their careers, any tips for them?
Take a McKenzie course. That would be my first tip. That was sort of my early introduction to orthopaedics, and that has kept me in good stead for my career. And so start with McKenzie Lumbar A. You are going to learn a logical system to looking at spinal pain and then extremity pain. And I would highly recommend that. I think that is downplayed in our education system, and I think it's wrong. I think that is the basis of how we should learn about orthopedics. I really do believe that. And then for every tissue-based course you take one psychosocial course. It's a biopsychosocial approach. And if you don't balance it out, and if you don't learn how to communicate more effectively, use motivational interviews and cognitive behavioral therapy, if we don't learn those strategies, you will not be a biopsychosocial clinician. Mm-hmm. So that would be my encouragement to you.
Yeah. Yeah. And you're going to miss a lot of patients if you don't go on that approach as well.
Yeah.
Carolyn, if people want to learn more about you or find you or your website, your courses, how they can find you?
Yeah, 2 ways. Certainly email me. Happy to take emails. So Carolyn at reframerehab.com. So REFRAME rehab.com. You can look up Reframe Rehab. We've had a little bit of a hiatus in courses over the last year because my husband has struggled with some illness. And so we're just starting to kind of get back to that again. We have put a lot of our courses on Embody Academy. So that's EMBODIA Academy.com. And there's a bundle of courses that what we've tried to do is actually take all the basic skill sets in taking a biopsychosocial approach and putting it into a course bundle of 6 courses from 6 highly skilled teachers. And that whole bundle is only $699. So you get 6 full courses for about $100 a course. So that's probably your most economical way and that's Canadian dollars. So if you are in the US listening to this, that's a real bargain. Take about another 30% off that. Maybe awesome. 35 because of our dollar. Yeah.
Yes, that's awesome. I'll make sure to put that on the notes, on our show notes, put the link so people can go check it out and take the first step.
Yes. Just what is your next step? That's what I always say. What's your next step? Take one and move in that direction. Right.
Yeah. Awesome. Well, Carolyn, thank you so much for taking the time to come and share your knowledge with us. I love just listening to you, how you integrate everything, because I think that's hard. We have a lot of great therapists that are in different areas. And it's just great to hear someone that's integrating all of these and, helping us to just be better clinicians.
You know what? We are all good clinicians. Let's just start there. We all just need to take another step towards becoming a better clinician.
Yes.
Awesome.
Thank you so much.
You're welcome. Thank you for having me.